Hello everyone. So today we'll discuss DCML. DCML means dorsal column medial lemniscal system. So why this is called dorsal column? Because it starts from the dorsal column of the spinal cord. So before going into the proper track, we must know what are the functions of the DCML system or what are the sensations that it carries. So number one is touch. So we have again two type of touch, fine touch and crude touch. So DCML is mainly responsible for fine touch. So number two is pressure. Then proprioception, that is joint sense. Proprioception, that is joint sense. Then vibration. Then stereognosis. Stereognosis is the way where you can identify any object with closed eyes. Like if you close your eyes and we put something in your hand, then you will be able to say what is that object by touching and feeling that thing. So that ability is called stereognosis. And 2-point discrimination. 2-point discrimination. So 2-point discrimination is the system by which is the ability by which we can diagnose if we keep 2 points or if we stimulate 2 points in our skin, in our body at the same time, then we can say that this is stimulated by there are 2 points here. Or if we take 2 needles and put it very close, then still we can say there will be 2 points of stimulation in our skin. So the way you differentiate between 2 points is called 2-point discrimination. So this dorsal column medial lemniscal system, it has 6 functions, like it carries fine touch, then pressure, it carries the proprioceptions, that is the joint sense, that is very important, like our joint tell our brain that where the moment where your body is located in the space. Like if I'm standing right now, then my knee joint and my ankle joint, they will tell us, they will constantly coordinate with cerebellum and cerebral cortex and tell our brain that you are standing or you are sitting by the position of the joint. Then vibration, as you know, the vibration, if you place a tuning fork, then it's a vibration sense. So that vibration sense, sorry. So and plus stereognosis, that is ability to diagnose a thing with closed eyes, and ability to diagnose 2 points is called 2-point discrimination. So these are all DCML functions. So dorsal column medial lemniscal system. So let's now understand the tract, how it starts and where it ends. So it starts from the spinal cord. So start from the receptors. So we have few receptors in our skin which carries these sensations, like Merkel's disc, Pacinian corpuscles, like Ruffini end organs, and even the muscle spindle. So these are the receptors which carry the sensation of touch, pressure, vibrations, joint sense, all these things. They carry the receptors, and they will convey the. So from here, from the skin, they will. So let's say here that. Let's say this is the receptors, and it is connected with a nerve, and it is axon. So when you touch our skin, someone touch the skin, these receptors will be activated. They will be activated. So when the receptors will be activated, then they will send the signal where they will send the signal to the spinal cord. Okay. So this is the spinal cord. So these axons which are traveling from these receptors, they will now, let's say this is the anterior part, this is the posterior side of the spinal cord. So they will go to the posterior horn of the spinal cord. So because it is going through the posterior side of the spinal cord, that's why you call dorsal column. This is called dorsal column, this is called ventral column. So they will go to the, this is called ventral horn, this is dorsal horn, sorry. So they will go to the posterior horn of the spinal cord and then go to the posterior column. This is in the white matter. So they will go to this white matter and then it will ascend up. So this is one axon. So we call it the first order neuron. We call it the first order neuron. So this first order neuron will start from the receptor. Suppose someone touch the skin and this will be activated and the action potential will travel from here and from the spinal cord, from the posterior horn of the spinal cord, it will ascend upwards. So these fibers that is going up, we call them as the gracile fibers. Gracile fibers. So gracile fibers are the fibers that carry sensation from our lower limbs. So from the spinal cord, it will go up. It will go up to the medulla. Okay. So this is the first slide. Now let me draw the second slide here. So the DCML tract, it starts with the receptors. So let's say this is a Pacinian corpuscles or a Merkel disc, which is connected to an axon, which is a nerve fiber, axon, and it goes to the posterior horn of the spinal cord. So this is the anterior horn, this is the posterior horn. It goes to the posterior horn of the spinal cord, then it will go to the posterior column of the spinal cord in the white matter. From it, it ascends up and it ends up in the medulla. Where it end up? It end up in the gracile nucleus. So there are two pair of nucleus. One is gracile and this is cuneate. Gracile, cuneate. So gracile nucleus and cuneate nucleus. So this first order axons, we call it first order because they start from the receptors and they carry the sensory sensations. So whenever someone touch, they feel it and action potential will develop and it goes to the posterior horn, to the posterior column of the spinal cord and ascends up and terminates in the gracile nucleus. So these gracile fibers, these are called gracile fibers. So these gracile fibers that end up in the gracile nucleus, they carry mostly the lower limb fibers. They are lower limb fibers. Lower limb fibers. So all the lower limb sensations like touch, pressure, vibrations, they are carried by gracile fibers, which end up in the gracile nucleus. After the level thoracic 6, at the level of T6, these are also joined by, at the level of T6, all the sensory informations from the receptors, they are going to the cuneate nucleus. These are cuneate fibers, and they carry sensation from upper limbs. So gracile fibers carry the lower limb sensations, while cuneate fibers carries the upper limb fibers. So these are for upper limb, this is for lower limb. So if you see here in the spinal cord, the lower limb fibers are most medial and upper limb fibers are lateral. Now this is the first order neurons. This is the first order neuron because it starts from here, from the receptors and end up in the medulla. Okay, so these are first order neurons. These are called first order neurons, and together we call it dorsal column. So dorsal column consists of gracile fibers and cuneate fibers. Alright, now from here, at the level of medulla, what happens? These fibers cross to the opposite sides, which are called internal arcuate fibers. They cross to the opposite side. Okay, and so left side fibers goes to right side fibers goes to left side. So from here the second order neuron started. So this is the second order neuron. So here the second order neuron started. And where they go? They go and terminate in the thalamus from both sides. They go and terminate in the thalamus. Okay. So cuneate fibers are carrying from upper limbs. Gracile fibers are carrying fibers from lower limbs and they end up in the thalamus before crossing. So at the level of medulla, fibers from each side, they cross to the opposite side. they cross to the opposite side. Remember that. They cross to the opposite side. So this is medial lemniscal system. So this is called lemniscal system. That's why we call DCML, dorsal column. This is dorsal column, medial lemniscal system. So here, the whole things that is, now you see that this is the lower limb fibers, G for lower limb fibers, C for cuneate fibers, the upper limb fibers. So they are lying in the midline like this. So right side fibers, these are, we are talking about right side of the body. So after the medulla, this dorsal column medial lemniscal system, they rotate at 90 degree. They rotate 90 degree. Means the leg fibers are anteriorly, ventrally, and the head fiber, the upper limb fibers are dorsally. And also after the level of medulla, it will be also joined by the trigeminal nerve. So trigeminal nerve at the back, which will carry the sensation from the face and head and neck. So there will be now from ventral to dorsal. From ventral to dorsal, it is the leg fibers, lower limb fibers, then upper limb fibers. Okay. So if I standing like this, so my ventrally it is the leg fibers, lower limb fibers, that is gracile fibers, then upper limb fibers, and then face fibers. The fibers coming from the face, that is trigeminal nerve, which also joins this medial lemniscal system. So this medial lemniscal system consists of three kind of fibers. Okay, it consists of three fibers. One for the leg, another for the upper limbs, and another for the face. It consists of three fibers. So this medial lemniscal system, it end up in the thalamus. It end up at the level of thalamus, where it end up at the VPL nucleus, at the ventro-posterior-lateral nucleus. Ventro-posterior-lateral nucleus. It will end up there. So this is the second order neuron. This is called second order neuron. So this is first order neuron, which end up in the medulla from the receptors, and from the medulla it ends up in the thalamus. It is the second order neurons, and from the thalamus, where it will go to the post-central gyrus. We know that after here there is the central sulcus, front is the motor area, back is the sensory area. So it will go to the somatosensory cortex. So here this is the third order neuron that has started from here, third order neuron number 3, and it will end up in the somatosensory cortex. It will project into the somatosensory cortex. So you can see that right side of the body is going to the left side of the brain. Left side of the brain. So right side of the sensory systems, sensory fibers are terminate in the left side of the cerebral cortex, in the post-central gyrus. In the post-central gyrus. And the right side of the brain, it receives the fibers from the left side of the body. So what sensations they are carrying? They are carrying 6 sensations. Touch, okay, they are carrying touch, fine touch, they are carrying pressure, they are carrying vibration, they are carrying proprioception, that is the joint sense, then 2-point discrimination, and stereognosis, means ability to diagnose things with closed eyes. So these are the 6 functions of DCML. So this is the first order neurons. Let's recap. First order neurons, then second order neurons which terminate here, and from the thalamus it is the number 3, third order neuron. So this is the tract, dorsal column, medial lemniscal system. Okay, so this is the, now we have to know what are the disorders. Okay, so before that, what are the points to remember? Remember the upper limb fibers and at the spinal cord at the level of thoracic 6, which you must remember that. Means if there is an injury below T6, thoracic 6, then upper limb fibers will not be affected. Only the lower limb sensations will be gone. Because at the level of T6, only upper limb fibers, they enter as cuneate fibers and end up in the cuneate nucleus. Right. So another thing to be noted here, that lower limb fibers are most medially. Okay. Even in lower limb fibers, the fibers that are coming from the toe, they are in the most medially. So let's say this is the coming from our toe. Okay. So the fibers coming from the toe, it will go to the posterior horn. It will lie most medially to the center. So that means what? If there is any spinal tumor which is growing in this way, so which fibers will be affected first? obviously the lower limb fibers, the gracile fibers will be affected first. If the tumor is growing like this, the gracile fibers will be affected first, because if it grow like this, the gracile fibers will be affected. And out of the gracile fibers, the fibers that are coming from the lower part of the lower limbs, they will be affected faster. They will be affected before the fibers coming from the thighs or the knees. So big toe fibers will be always affected fibers. It will be affected first because it is close to the midline. So it is arranged like this. So medially this is the big toe, then from the ankle, so then from the knee, from the thighs. So the fibers are ascending like this in the gracile fibers. So together we call it the tract. So they're like this. So when a tumor grows in like this, and a tumor, then it will affect the fibers in this fashion. First the coming from the sacral fibers, coming from the toes, then the knees fiber, then the thighs, and in this manner, then upper limbs as it grows. Obviously, if it is the tumor is above T6 level. Excuse me. So that is the clinical significance. Okay. So let's say now, what are the DCML problems or DCML clinical significance? So you have to know that this thing, that we know if there is a DCML problem, then the person will complain of that they cannot feel the touch, fine touch, they cannot feel pressure, they cannot feel the proprioception, joint sense, and most of the things will be, the sensory coordination will be lost. So how will you diagnose if this is a DCML? First thing, how will you diagnose that this, when the person is ataxic? Ataxic means ataxia or ataxic means when a person is having difficulty in gait, when he cannot walk properly, or he is having problem in speech, he can speak fluently, or he is having problem in eye movements. So ataxia is a neurological disorder when there is a loss of sensory coordinations. Now we can say that why there is a problem in walking, though it is a sensory fibers that are being destroyed or that are being disturbed. Now without the sensory input, motor functions cannot do anything. We know that the post-central gyrus is constantly in communication with pre-central gyrus. So they are telling the brain, apart from the input from cerebellum, there is also the cerebral cortex is involved, and the post-central gyrus is constantly communicating with the premotor area and supplementary area and telling where your body position is, so that the motor pyramidal tract can act efficiently. So if there is a sensory information is not passed to the brain efficiently, there will be problem in walking. Okay, that is called gait. Okay, that is called, which we combine, we call it ataxia. Now if a person is ataxic, now we have to diagnose this ataxia, whether this is because of, so if a person is ataxic, either this is because of DCML, we are excluding the alcohol and other causes, drugs causes, either it is because of DCML or it is because of cerebellum. Now how will we check it? Now remember, to keep the balance of our body, we need three things. We need visual input, we need auditory input, that is from the ears, and we need proprioception. So we need three things to stand in a proper place, and if I have to stand steady in a stable manner and I don't lose my balance, for that we need three things. We need visual input, we need auditory, that is the vestibular apparatus is there inside our inner ear, the auditory input is there, so vestibular input, and we need joint sense, the proprioceptions. Now even then, if we remove one of these three impulses, the other two stimulus, they can still maintain the balance. Okay, like say we ask the person to stand still and then he closes his eyes. Then closing eyes means we are deleting this factor. So visual impulse is gone. So if a person, when closes his eyes, he still cannot maintain a balance steadily and he is about to fall, or to and sway movements, or you can say loss of balance when someone closes eyes, then the problem is either because of auditory, that is the vestibular apparatus, or it is because of proprioception. So if a person cannot maintain the balance when closing his eyes, we call that as a Romberg's test positive. That is the basic behind this Romberg's test. Romberg's test is positive. So the concept is that if a patient is Romberg's test, if a patient, ataxic patient is Romberg's test positive, then this is because of DCML lesion. This is because of some DCML lesion. It is because of DCML disorder. Okay. And if a person is ataxic, but his Romberg's test is negative. Okay. So if a person is ataxic, so let's say a person is ataxic, but his Romberg's test negative. Romberg's test negative. Okay. Then this is not a DCML, then this is because of cerebellar disorder. Cerebellar disorder. So in this way we will differentiate whether he is ataxic, the cause of ataxia is because of DCML or because of cerebellum. That's why doing the test that is called Romberg test is very, very important. Other than this thing, Romberg's test, now what are the clinical disorders that you will find which is quite frequently associated with DCML lesions? So very commonly is the posterior cord syndrome. Okay, so posterior cord syndrome or posterior spinal artery syndrome. Spinal artery syndrome. So whenever this posterior spinal artery is affected, either because of infarct or because of blockage or compression or disc compression, then person will have difficulty in sensory input, because the dorsal column, that is the posterior column, which is so excuse me. So we are talking about that in the posterior column. So we know that posterior, this DCML tract, it goes to the posterior column. Okay, this is the midline, it goes to the posterior column. So this posterior column part, this part is supplied by posterior spinal artery. It is supplied by this posterior spinal artery. It is supplied by the posterior spinal artery. So if the posterior spinal artery is blocked, like there is any compression by the disc, or there is any infarction, okay, or any tear or any injury, then this whole sensory DCML part will be affected, and person will have then again loss of coordinations. All the sensory inputs will not be going to the cerebral cortex. And very interestingly, remember this, it is often asked in the exam, where this posterior spinal artery comes from. So posterior spinal artery, it comes from the vertebral artery. Okay, posterior spinal artery, it is a branch of vertebral artery. Now if you remember, this is the left ventricle, and from the left ventricle, this is the arch of aorta. Okay, so in the arch of aorta, we know there is a subclavian artery, going on, and it becomes the carotid artery, then vertebral artery. So from the vertebral artery, the spinal artery comes out. So this posterior spinal artery, it comes out of the vertebral artery in 25% of human beings. 75% of human beings, the posterior spinal artery, it comes out of the posterior inferior cerebellar artery. So this is posterior inferior cerebellar artery, which is going to the cerebellum. So 75% of individuals, the posterior spinal artery is coming out of the posterior inferior cerebellar artery, while 25% is coming out of the vertebral artery. So this posterior spinal artery, it goes in the posterior column of the spinal cord, and it supplies the posterior column of the spinal cord. So in any case, when this posterior spinal artery is affected, then there will be also DCML disorder. Other than posterior cord syndrome, most often asked in the exams is the genetic disorder, so it's called Friedreich's ataxia. So this disorder is called Friedreich's ataxia. This is a genetic disorder. So ataxia, you know, that difficulty in movement, when a person is not able to maintain the balance while walking. So Friedreich's ataxia is an autosomal recessive disorder. Autosomal recessive disorder due to defect in chromosome number 9. So in Friedreich's ataxia, it is genetic disorders, autosomal recessive, and there is problem in walking, a person cannot walk properly, there will be problem in speech and sensory sensations like fine touch, vibrations, all these things. And this Friedreich's ataxia is one more thing is very common in the exam, because it is also is very associated with hypertrophic cardiomyopathy. Don't forget, it is often associated with hypertrophic cardiomyopathy. So what happens in Friedreich's ataxia, the posterior column, the spinal cord, mostly it is demyelinated. So because this is a genetic disorder, the chromosome number 9 is responsible for synthesis of one protein called frataxin. So when this chromosome number 9 is defective, this frataxin is not synthesized properly, not produced properly. So as a result, there is demyelination of nerve fibers and spinal cord thins. So when spinal cord thins, the posterior column is very much affected, and there is a problem with the sensory order, DCML signs and symptoms. So this is a neurological disorder, and this is because of loss of myelin sheath or demyelination or thinning of the spinal cord, which is also very much associated with DCML. So this is about DCML and its tract and its clinical associations. That is Friedreich's ataxia, and number 2 is posterior spinal artery syndrome or posterior cord syndrome. Thank you.